Jane, can you hear me?
Yes.
Sweet, thank you.
Yep.
Oh, can you see the slides too?
Yeah.
Cool, thank you.
Yeah, she can take too long. So for us to do that, I should be back for the office. I can leave at 9. Sometimes that's all. I don't think there's anything else I need to talk about. Okay, sounds good for that fair life.
What is that?
Protein shake? Not. They're from Costco, but if you really like Fairlife, it tastes very similar. And so I love that they choose one of the big.
So the sign under says martial arts is canceled.
It is.
Yeah. Thank you, Robert.
Let him know. I'm like,
The problem is, I have an approved flash drive. Where I can the video flash drive. Yeah, I gotta walk in with a laptop or something. Don't pick it up. But what do you get to say about the fan? You let him know. I don't know. That means he has to physically come back. You let him know. Okay. I think he would do that. Well, you gotta tell all your guys. And there must be a otherwise,
He's the only one that's asked for the.
okay. That's fair.
Sometimes.
How are we on battery?
I
We
think
can.
great. Dr. Stevenson.
Oh, it's dead.
Oh, it is?
Well, here it is.
Yeah.
I know.
Yeah, I have the
Back.
Oh, it's gonna die.
That's your batteries. Oh, yeah, it's gonna die.
Yeah.
Yeah.
Sorry, until like this one.
And so I made a mistake in this one, but not just suck it up, tuck it up. Right here. I thought I was getting some powder. I should have done it like, so it's getting it right there. I mean, sure.
I think it needs to go on show up. I was gonna have him field some of the questions.
Couple people.
It will be my first and last.
Good girl.
She knows like.
Walk away. Check 1, 1, 2, 2.
I don't wanna do anything.
Right.
0 out of 10.
Make sure we're.
I just wanna like. It's just, and you're like, oh, look, the next time you should be seen where. Like this, you're like, oh, look, and then you put that in.
Feels nice.
Yeah, and I think it's fascinating to anybody to do it at all, so. Yeah. Hello, Boyd. I know it's You look fabulous. So stylish.
Good morning, everyone. Just morning, we have Dr. Stevenson, a graduate of the University of Utah School of Medicine. He completed internal medicine residency and infectious disease fellowship at the University of Iowa. Got his master's of public health degree from the School of the University of Washington. He was most recently a professor with tenure at the Ohio State University with the division of infectious disease, and was the medical director of the Antimicrobial Stewardship Program for the Western Medical Center for 16 years. Since he moved to the Boise VA, he is now the clinical professor in the Division of Allergy and Infectious Disease at the University of Washington.
Thanks. Is this mic working? Okay, he's got it, all right. Well, good. Well, I noticed that out front it says the martial arts class has been canceled today. Maybe that's why nobody's here. Anyway, about once a year, I've tried to give a lecture like this particularly to the residents, because fortunately at the Boise VA, we don't see a lot of really multi-drug resistant pathogens. So there's a lot of antibiotics and that may not be familiar with. So I wanted to kind of review this, and hopefully it'll be helpful. This is not gonna work.
Oh, no, it's gonna work. Okay, click. There you go.
Okay, so I don't have any financial or other conflicts of interest, and then have the usual VA disclaimer that I'm solely responsible for this content, doesn't represent the views of the VA. So what I'd like to do is review just some interesting things about the unique origins of antimicrobial resistance, and maybe just dispel some myths that you may have heard. Then we're going to look at the most clinically important resistant organisms, but I really want to focus on MDR gram negatives, and really focus on beta-lactam antibiotics, and just because those are the most common drugs that we use for treatment of these infections. So this is just a schematic of the gram-positive and gram-negative cell wall, which you're probably familiar with. But the main thing to point out is the gram-positive cell wall is all peptidoglycans. And then there's some of that in the gram-negative cell wall, among other lipid layers put in there as well. And the peptidoglycans, are the synthesis of that cell wall component, is what the beta-lactam antibiotics target. So I will mention some of the other mechanisms of resistance with gram-negatives, like poron mutations and efflux pumps and some of that stuff, but that's kind of beyond the scope of what I wanted to discuss today. So this is, you should all be very familiar with the classic gram-positive bacteria. The gram-positive cocci, staph, and strep species, Enterococcus, we're all very familiar with, we see regularly. The Bacillus species, other than I don't think, Dr. Vitri, we've had a case of anthrax here. Dr. Vitri is an expert in anthrax, so. But there's Bacillus cereus, it causes food poisoning, we might see occasionally. Listeria, we see rarely. Clostridium C. difficile, we see on a regular basis. And then Corynebacterium is generally considered a contaminant, but there is Corynebacterium striatum, which is probably a real pathogen. So these are organisms you're all familiar with. Now the gram-negatives are a little more complicated. So I know this is hard to read. I'm just going to point out that we have the lactose fermenters and long non-lactose fermenters, which are most of the organisms we see, the Enterobacteriales group. And then among the non-lactose fermenters, we also have Pseudomonas and Stenotrophomonas and Acinetobacter, and those. And we'll talk a little bit more about those. So, but it's a much more complicated family of organisms. And if you ever have a chance to go to the microbiology lab, the texts are very helpful about, if you have a gram-negative, they can show you the different plates that distinguish based on these biochemical features. So this is a quote that I picked up a long time ago at a meeting. I actually went to the Time magazine and looked it up to make sure I wasn't misquoting this, but the thought in '66 was, by the year 2000, all bacterial and viral infections will be wiped out. We will have also conquered arteriosclerotic heart disease. Now we can laugh at that now, but I think at the time, nobody really appreciated the impact of antimicrobial resistance and what a role it was going to play. And so even the economists, this is from the World Economic Forum, said arguably the greatest risk to human health comes in the form of antibiotic resistant bacteria. And having done some work overseas, in Africa and China, there's huge problems globally with antimicrobial resistance, and a lot of it has to do with overuse of antibiotics. So this is an old from Science magazine, Science, the journal, just this review article. The only reason I point it up is that if you notice, it only takes a few years from the time an antibiotic is introduced until resistance develops. So like cephalothin, which is the precursor to cefazolin, introduced in 1964, and resistance was noticed by 1966. Interestingly, the penicillinase that destroyed penicillin was discovered in Staph aureus even before penicillin was really on the market. And then this just goes on up to 2002 with some of the more resistant pathogens. It's not, like I say, it's an old article, but the point is resistance develops pretty quickly once we start using antibiotics. So this is the let's see, the campaign to prevent antimicrobial resistance in healthcare settings was a CDC campaign that was started in the 90s. They actually had a 12-step program like Alcoholics Anonymous, but for against antibiotic resistance. And this is a couple of slides from that. So the traditional paradigm is that somebody's on antibiotics, they mutate, and they become resistant. That's what I, grew up always thinking. We force mutations by introducing antibiotics. And the current paradigm is that resistance genes get transferred between resistant to susceptible bacteria. And let me go into that a little bit more. So, we know a lot about integrons and plasmids, and there's a lot of gene transfer that occurs in bacteria. And so it's very easy if you have a resistance gene on a plasmid, to go from a resistant bacteria and transfer to a susceptible bacteria. And that's probably the biggest mode of resistance development. So what then happens is if you have a resistant strain in a population and then you expose to antibiotics, then you get antimicrobial resistant population. This is common like in the ICU where we use lots of broad spectrum antibiotics. So it's probably based on this selective pressure that made us think, well, we expose somebody to antibiotics and that a bunch of resistance develops, but it's mostly selecting for those few resistant pathogens. So the traditional paradigm was mutations occur and they develop into antimicrobial resistance. And I'm proposing the current paradigm is that most of the resistance occurs by gene transfer between antibiotics and through selection pressure. So interestingly, most of the resistance genes probably existed a long time before we even had antibiotics. We know that in microbial populations and environments, bacteria and fungi develop resistance mechanisms to protect themselves to survive in the environment. So like we know penicillin came from a mold, Penicillium, and streptomycin came from Streptomyces, and so we know these antibiotics are being developed in nature. And so interestingly, there's two studies I just wanted to share with you briefly. One was there's this cave in New Mexico that they proposed had been blocked off or sealed off for millennia. And when they got in there, they were able to collect microorganisms from the cave environment, and they tested them for antibiotic resistance. And if you look here, they found that you can see there's a large number of resistant strains of even piperacillin, daptomycin, the very bottom, 24 strain. Daptomycin wasn't long even on the market or invented before, or it was invented, obviously they tested for it, but it wasn't widely used at the time of this study. And these are some of the gram-negative. So here's an ancient population of organisms that showed demonstrated antimicrobial resistance. And then another study was this, a mummy from an Andean mummy that they got in, opened the mummy, got flora out of the mummy and tested for antibiotic resistance. And again, you can see there in the descending transverse colon, ascending colon, there was all kinds of resistance and resistance genes. VAN-A, which is the gene for the vancomycin resistant enterococcus and so forth. So the thought is that a lot of these resistance genes are pre-existing in nature, in commensal bacteria. They find their way into pathogenic organisms, and then through antibiotic selection, pressure, and gene transfer, we develop these resistant populations. Just to give one example, I don't have a slide on, but vancomycin resistant Staph aureus, they demonstrated if you take vancomycin resistant enterococcus that has a VAN-A gene and mix it in a test tube with Staph aureus, the gene transfers and you get vancomycin resistant Staph aureus. So they did that in the test tube. And then there was, in the great state of Michigan, I say that being from Ohio State, but in Michigan, they had a lot of drug addicts and Staph aureus and MRSA infections in Detroit and area using lots and lots of vancomycin. They demonstrated that in patients that had VRE and MRSA in their wounds, the MRSA picked up the VAN-A gene from enterococcus and became vancomycin resistant. So we know that this transfer occurs. So I just wanted to throw this in there that maybe this will change a little bit about your thoughts on where does resistance come from. And like I said, I think a lot of it is pre-existing resistance. And as I'll show you with beta-lactamases, there is a lot of evolution going on based on antimicrobial pressure as well. So this is just the current paradigm. Resistance occurs from the transfer of resistance genes from commensal to pathogenic organisms and spreads due to antibiotic pressure. And most of these genes probably long existed. So anyway, so this is just a list of antibiotics and the mechanism of action. And we're going to really focus on the beta-lactams. And if you remember, this is just the basic beta-lactam ring. So if you remember, all of the beta-lactam antibiotics are developed from this structure. So the beta-lactamase antibody, or enzymes rather, cleave that beta-lactam ring. And that's so they inactivate the antibiotic through that mechanism. So beta-lactamases are these enzymes that inactivate beta-lactam drugs. And, the beta-lactam drugs, if we just lump them all together roughly, is penicillin, cephalosporins, carbapenems, although carbapenems are technically not the true beta-lactam. And there's two major classification systems, the Ambler system and the Bush-Jacobi system. And the Ambler system breaks beta-lactamases into four groups. A, B, and D are, if you remember your biochemistry, the active site of the enzyme is a serine molecule. And then there's the B group is the metallobeta-lactamases, where they have zinc is at the active site. And that's important, we'll talk about in a minute. And then the Bush group looks more at functional characteristics. So they group one and beta-lactamases are the class C cephalosporinases that have lots of activity against a variety of different cephalosporins and penicillins. Group two are the ones that are the more display much greater antibiotic resistance potential, the ESBL enzymes and broad spectrum resistance. And then the group three are the metallobeta-lactamases. So overall, there's 17 functional groups, and this is just a schematic of, this is, very complicated nomenclature. And so I'm not going to go into it in any more detail than this, just to demonstrate to you that, this is a very complicated group, families of enzymes. In fact, this is just shows that the number of unique beta-lactamase enzymes that have been identified since we first introduced beta-lactam antibiotics. So you can see with antibiotic pressure, we're selecting out more and more resistance, and the beta-lactamases, as time has gone on, get broader and broader in their activity. So this just show you just the complication of, these are just from some of the early papers on the nomenclature. And these major families, if you notice along the far left side, there's different names. So you've probably seen some of those. CTXM is the gene that codes for the ESBL production. OXA48 is another class of carbapenemase that we'll talk about in a minute. So the CDC several times has developed topics or reports on antimicrobial resistance threats. And the ones that are up here, we've talked about MRSA and VRE briefly. We're not going to talk more about those, but carbapenem resistant enterobacteriales, MDR pseudomonas, and ESBLs and carbapenem resistant acinetobacter, we'll talk a little bit. And if you can see from this study from the CDC that these resistance patterns, for the most part, are increasing in frequency in the hospital setting. So the gram-positive, just to mention you should be very familiar with this. The gram-positive, because of the cell wall structure, the beta-lactam or the cell wall active drugs are the ones that are most effective against gram-positive. So for MSSA, we have nafcillin, oxacillin, cefazolin, oral regimen, cephalexin, trimethoprim sulfate, doxycycline, vancomycin and ceftaroline for MRSA, along with daptomycin for MRSA and VRE. And then we have these long-acting drugs that work against these more resistant staph, dalbavancin and iridavancin. I'm not going to really spend more time talking about these. I think you guys we use these all the time, and so you're pretty familiar with them. But with the gram-negatives, the beta-lactamases are the key treatment options that we have. But there's also other forms of mutation, efflux pumps, metabolic forms. And so some of the other non-beta-lactam drugs work by these other mechanisms. And with drug resistance, we often have to use those in combination. So there's, if you look at the sort of the hierarchy of drugs, if you look at that, think of that graph of the beta-lactamases increasing in frequency, the spectrum of activity is also increased. So we used to just have like penicillinase, the very initial beta-lactamase discovered, only destroyed penicillin. But now we have more specific penicillinases against other penicillin drugs, cephalosporin, cephalosporinases that are only going to work against first or second generation cephalosporins. And then there's a group called AMP-C, which is a broad resistance to all penicillins and all cephalosporins except for cefepime. And we'll talk a little bit more about that in a second. Then you have the extended spectrum beta-lactamases that basically destroy all the penicillins and the cephalosporins. And then carbapenemases, which induce carbapenem resistance. So this is kind of the hierarchy of, so what we use here at the medical centers, we're used to using penicillin, cephalosporins, the basic older beta-lactamase inhibitor combinations like amsulbactam or piperacillin tazobactam. We're very familiar with those. And then the carbapenems, which fortunately, we don't have to use carbapenems a whole lot. Ertapenem, you're probably pretty familiar with, and meropenem, we use some. And then there's a bunch of newer beta-lactamase inhibitor combinations, which I'll talk about. Polymyxins, which fortunately we haven't had the opportunity to use much here. And then there's the other non-beta-lactam drugs like aminoglycosides, fluoroquinolones, trimethoprim sulfate, which will often have activity against some of the more drug-resistant gram-negatives. So sometimes we have to use those in combination. So AMP producers, so these are very interesting. It's an AMP gene. It's on the chromosome. It's inducible. And so and it's kind of tricky. I remember when we first started seeing those, I had a patient in the ICU that came in with an Enterobacter pneumonia, ceftriaxone susceptible. We put the patient on ceftriaxone. They're not getting better. They're getting worse. In a couple of days, we reculture them. Now the ceftriaxone is resistant. And that's the typical pattern with AMCs. So basically, this inducible resistance, and there's strong inducers that are listed here and weaker inducers. And usually, if you just think of this group of AMC producers, so we used to call them space organisms or spice organisms, or spice M if you throw in Morganella. And then there's this newer mnemonic or acronym, heck yes, that has some of these other ones. But normally, if we see particularly the Enterobacters, the Citrobacters, Serratia, if we see a patient with those, often we'll just empirically say we're going to just use cefepime, because the likelihood of them having an AMC gene that's going to get turned on by another drug is high. So think of AMC, think of cefepime. And then the extended spectrum beta-lactamases are, again, they have activity against all the penicillins, all the cephalosporins. And so Klebsiella pneumoniae and E. coli are the most common ones, but they've been reported with all these other gram negatives. They're plasmid mediated, so they can transfer between organisms. And they're based on, they are mutated from native beta-lactamases. So if you remember on that one table where it had all those different names like TEM1, 2, SHIV1. Anyway, those are all beta-lactamases that have been modified and have now developed this extended spectrum activity. So the gene that is most commonly seen is this gene called CTXM. So you've probably seen on the BioFire, we get a blood or any BioFire where we're looking at gram-negative susceptibility. They'll have the CTXM gene. And if that's positive or detected, then we suspect that it's an ESBL producer. So you just so you're familiar with that gene. So these are, like I said, resistant to the all the first, second, third generation cephalosporins, resistant to monobacteriums like Astrinam and penicillins, even to Cryptazo and so forth. And so, again, the carbapenems are the drugs of choice. Ertapenem is, we don't need, the broader spectrum carbapenems against Pseudomonas, we don't usually need in this setting. So ertapenem works great. But sometimes the non-beta-lactam drugs like quinolones or trimethoprim sulfa will work as well. And then fosfomycin has activity, but it has such a limited penetration. You could use it in a urinary infection where it's purely cystitis, but it's not going to be used for systemic treatment. And this is just give you an example of what are all the risk factors for somebody developing an ESBL producer. And usually people that are in intensive care units, in nursing homes, a lot of antibiotic exposure, people who have decubitus ulcers, indwelling catheter. These are people that all become colonized with these more drug-resistant organisms. So we do see a fair number of ESBL producers in our hospital here. So yeah, I think most of you should be at least somewhat familiar with treating them. But just think, unless it's Pseudomonas or maybe Acinetobacter, ertapenem should work. And then this is an old study I just put up that shows that 40, in some areas in Latin America, and this was old, among Klebsiella and E. coli, up to almost 50% of organisms were ESBL producers. So it's globally, it's a big problem. And I know when I was at Ohio State, we had a large number of our Klebsiella and E. coli were ESBL producers. So But we do see that here. Now, the carbopentamases, if we keep going up the spectrum there, they inactivate all, basically, the penicillins, the cephalosporins, the carbapenems. And so the bacteria are resistant to most treatment modalities. And there's these different groups. The KPC group, which stood for Klebsiella pneumoniae carbapenemase, is the one that we see most frequently. And for a long time, we used to just talk about KPC producers. And with these other carbapenem resistance becoming more frequent, the CDC's just used the term CREs. So just carbapenem resistant enterobacteriales. So this isn't Pseudomonas or Acinetobacter, it's just all the Klebsiella, E. coli, Serratia, that group. The NDM1s, we'll talk about more in a minute. They're a class B, they're a metallo-beta-lactamase, and they're a little bit special, we'll talk about in a minute. And then OXA48 is a class D, which is, remember I mentioned on that other slide, they're a little bit more, have a little bit more difficult resistance and more broader spectrum resistance. And those are a little special as well. So this is just to give an example, an old study in New York, in Brooklyn. There was 96 isolates of KPC Klebsiella that was carbapenem resistant, and it spread between 10 hospitals in Brooklyn. And this is back before we had some of the newer drugs I'm going to talk about. So they were susceptible only 50% to aminoglycosides, 90% to polymyxin B, and tigecycline. So, which tigecycline we don't use, but it's a tetracycline drug that at least initially had good activity against some of these organisms, but it's since there's been a lot of resistance developed. Now the NDM1 is called the New Delhi metallo-beta-lactamase 1, and it's found in Klebsiella and E. coli, and it's been reported now across the United States, and it's a class B metallo-beta-lactamase enzyme. So this is just the original study. So in a lab in India and Pakistan, they were screening regularly for carbapenem resistance. And in 2008, 2009, they saw this huge jump in carbapenem resistance. And the blue represents metallo-beta-lactamase. So they had this big jump. And so they started doing surveillance and found that these isolates were all over Bangladesh, the Indian continent, and also because of a lot of the movement between the Indian continent and the UK, there was a lot in the UK. So because it was first described in New Delhi, they dubbed it, I think much to the chagrin of the Indian government, called it the New Delhi metallo-beta-lactamase. But we don't see much. When I was at Ohio State, we had a patient I remember from Bangladesh who came in who had a big abdominal abscess that had an NDM Klebsiella. So, and we'll talk about the treatment here in just a second. So this is just one of many papers that reviews, and actually, if you go to Open Evidence or Up to Date, the review of how to treat these drug-resistant gram-negatives is really quite good. So the older treatments for CREs were the polymyxins, colistin or polymyxin B, plus or minus meropenem. And we did, when I was at Ohio State, we did a study with a group with some people from Detroit and a large study that recently got published, looking at if you add colistin plus meropenem or colistin alone, and unfortunately it wasn't, the study wasn't really great in showing the benefit of these older treatments. Aminoglycosides, tigecycline, rivacycline, which is a tetracycline as well, phosphomycin for UTIs. These are older treatments, but really they're not that effective compared to the newer drugs. So let me just tell you, these are the newer treatments. So for the KPC beta-lactamases, these are all beta-lactam, beta-lactamase combinations. So ceftazidime and avibactam, or AVCAS, which we have on formulary here, and we've used a little bit, but not much. Meropenem, vaborbactam, imipenem, relebactam, and cefiderocol are all drugs that work well against the KPC beta-lactamases. And Pseudomonas, as we'll talk about in a minute, you have to kind of do susceptibility testing, but ceftolozane, tazobactam is the one that most commonly works for Pseudomonas. And then the metallo-beta-lactamases, the only thing that really works is ceftazidime, maybe Bactam plus aztreonate or cefiderocol, which we'll talk about here. So this chart basically shows which enzyme, which beta-lactamase inhibitor has activity against these different groups. And you can see that none of them have activity against class B, the metallo-beta-lactamases. And the only one that has activity against OXA48 is avibactam. And cefiderocol, which we'll talk about in a second, has activity against all of them. So which mechanism of resistance, you have to have the right beta-lactamase inhibitor to have drug work. So cefiderocol, you should, every morning when you get up, you should say cefiderocol 5 times, just to wake up. So a very interesting drug, and we have it available, but it's not really generally always on the formulary. You don't see our ID pharmacists here to confirm that, but it's a very interesting drug. It has a side chains that are, it has a similar structure to cefepime and ceftazidime, and then it's hooked to a side chain that causes it to be a siderophore. And a siderophore is an agent that gets into the cells through the iron transport system in the bacteria. So this just is a schematic up at the top. It shows that through the iron transport chain, it's able to get into the cell. And then based on its structure, it's resistant to the beta-lactamases. So that's why it has activity against a lot of these other resistant organisms. So really, the beta-lactam combinations are the things that we use the most frequently. And I'm not gonna, if you have some of these other forms of mutations or other forms of resistance, sometimes that's where we have to look at susceptibility testing and choose drugs based on the MICs and so forth. So let me just talk about a couple of these special cases. So Pseudomonas aeruginosa, we're all familiar with. It's a gram-negative, non-lactose fermenting bacillus. It's common in the environment and water. Reservoirs of infection can develop in intensive care units. They've had outbreaks of Pseudomonas in sinks and water faucets and other places. And it can cause ventilator-associated pneumonia. In the early, back when I was a resident or med student, they had big outbreaks in burn units with Pseudomonas causing, infections and burns and so forth. And so it causes bacteremia. It's the common cause of pneumonia in cystic fibrosis patients, causes a lot of healthcare associated infections. And then a board question is hot tub folliculitis. My kids always hated me when we went traveling and we went to a hotel and there was a hot tub. I said, you can't get in that hot tub. But I've seen a few so hot tub with Pseudomonas is in the water. People get little pustules all along their hair follicles, and it's also been associated with I actually saw a case of this when I was moonlighting as a resident, that it gets in in athletic shoes, the rubber insoles that get moist Pseudomonas can grow in there, and then if somebody steps on a nail and it goes through their shoe into their foot. I saw a patient that stepped on some kind of farm implement in Iowa and it went into their foot and they got a Pseudomonas infection in their foot from it. So those are kind of questions I like to ask on boards, so for IDs boards at least. So the initial carbapenem resistance was described at the University of Pennsylvania. And this is just the study. They looked from 1991 to 2000, saw this significant increase in imipenem resistance. And that was, at that time, imipenem was the only carbapenem that we really had available. And it showed increased mortality and increased hospital stay, as you would expect. And then Acinetobacter baumannii, we don't see this a lot. Trying to remember when I had a case of it here, but I don't know, Cassie, if you've seen any here.
Like true infections, no.
Yeah, so, but we had a couple of big outbreaks in our intensive care unit in Ohio State when I was there, because it would come in from LTACs and chronic nursing home patients who were colonized, and it would get spread around. But it's ubiquitous, it's non-fermenting, gram-negative. It causes all kinds of infections. It can cause just about anything: pulmonary infections, bloodstream infections, urinary tract, surgery, wound infections. And they have a high propensity for resistance. And there's been large outbreaks, as I mentioned. So, and they're related to procedures, urinary catheters. There's an outbreak at Hopkins where they had a wound, in their wound clinic, they had a pulsating, like a water pick thing they were using to clean out wounds, and that got contaminated with Acinetobacter, and they had a big outbreak in their wound clinic. So it is very common in the environment. In fact, we did, one of the microbiologists at the veterinary school at Ohio State wanted to collaborate with us and on looking at, they're interested in resistant salmonella, which we don't see much. But I said, why don't we look at Acinetobacter? So they did some molecular testing on a bunch of our isolates and found that the Acinetobacter had efflux pumps that would make them resistant to the cleaning agents. The glutaraldehyde or whatever they're using to clean the environment was not effective because the organism would be exposed and just pump it right back out. So these are bad bugs. Interestingly, I don't know if we know how they came in the US, but from the Iraqi war, a lot of soldiers were coming back with wounds that were infected with Acinetobacter. So this is just an example of an outbreak in Brooklyn. A citywide outbreak of multi-drug resistant Acinetobacter, 15 hospitals. It was transferred back around. And then also an outbreak in Johannesburg, South Africa. So those are just the introductions. So I'm going to go through in summary here just to some of the treatments. So for ESBL producers, and this is, I guess, the biggest takeaway from the talk is ertapenem is preferred, but meropenem or imipenem will also be effective, but you really don't need the broad drug for these. And then oral step-down therapy, there's, trimethoprim sulfa, the quinolones, and maybe fosfomycin in cystitis, or oral options. And there are some oral carbapenems, tebipenem and sulopenem, that aren't out yet, but they're on the horizon. I'm not going to really talk about them. And there's also some new oral beta-lactam, beta-lactamase inhibitor combinations that are oral. And these may give us some options for step-down therapy. And so the KPC, the classic KPC carbapenemase, ceftazidime, avibactam is the preferred agent, just because I think we've had more clinical experience with it. The others could work and probably would work, but the ceftazidime, avibactam is what we view. This is the only time I've ever used that here has been for a KPC producer. Now, OXA 48 is, and this is one and I need to probably talk to our micro lab about, I think we do with the biofire do look for these genes, but this is a little bit different organism. It has a class D carbapenemase, so it's a little broader spectrum and more difficult. So ceftazidime, avibactam is the only avibactam is the only beta-lactamase inhibitor that has activity. So for OXA48, you need to use, the others won't work. And cefiderocol does also work, and maybe some of the non-beta-lactam drugs might be needed. The metallo-beta-lactamases are unique because none of the beta-lactamase inhibitors seem to work against this enzyme, but using a combination of ceftazidime, avibactam plus aztreonam is shown to be effective, and cefiderocol also. So fortunately, these are pretty rare in the US, but they do occur. So, and based on the MIC data, there may be other drugs that would have to use in combination. Now, for MDR Pseudomonas, again, you have to look at, because there's different mechanisms of resistance, you have to look at the susceptibility data. But if it's a carbapenemase producer, ceftolozane, tazobactam, or Zerbaxis, that really, we have more experience with that drug combination than any of the others. But the others combinations could work, but you may have to use polymyxins or Cipro. And so fortunately, we haven't seen a lot of really highly drug-resistant Pseudomonas. And then MDR Acinetobacter, the carbapenemase-resistant Acinetobacter pneumoniae, or they like to use these abbreviations, CRAB. This is very interesting because we knew for a long time that you could treat these resistant Acinetobacter with amsulbactam, which doesn't make any sense, but it's the sulbactam component that was working. And so there's been a new drug out called sulbactam durlobactam. So sulbactam is the component from amsulbactam fame. And then durlobactam is a new novel beta-lactamase inhibitor. So this is what is the recommendation for this organism. A lot of the other beta-lactamase combinations don't work. And then often we may have to use the polymyxins, which I'll talk about in a minute, which hopefully we won't ever have to use here because of their toxicity. The tigecycline, when tigecycline first came out, we published a study at Ohio State showing that it was really effective against Acinetobacter infections. The problem is by the time we were getting kind of to the end of the study, the population we were looking at, we started seeing more and more resistance. And now I think tigecycline probably doesn't work that well. We used to use minocycline in combination with other drugs, and that has some activity. Again, it all depends on susceptibility testing. But I will say we had several cases of absolutely pan-resistant Acinetobacter. I mean, there was nothing that would treat it. So this is a scary organism. So let me just conclude, talk a little bit about polymyxins. So these are very interesting. They're cyclic polypeptides. They have a hydrophilic end and a hydrophobic end, and the lipophilic end. And the lipophilic end inserts into the membrane and basically disrupts the cell membrane. And I think of it as detergent. It's like a detergent, gets in and destroys the lipid bilayer. And it's particularly active against Pseudomonas and Acinetobacter when you have other drugs that aren't going to work. But it has a lot of neurotoxicity and nephrotoxicity, and which has really inhibited its use. And I remember I had a patient that had this is before we had the good combinations, had a pretty highly carbapenem-resistant Pseudomonas. I had our ID pharmacist help me over the weekend on a Saturday or Sunday, I can't remember, to dose the colistin. They gave me the dose, and within 24 hours, the guy's creatinine had gone from less than 1 to 6. they're just, and then there's a lot of neurotoxicity, so they're really hard to use. So thank goodness we don't have to use, and there's two groups, Clistin, that's what the Clistin looks like, and then polymyxin B, but you can see they have a hydrophilic end and a hydrophobic end. So resistance is developed to these. There's a study way back in 2007 in some Korean hospitals where 30% roughly of the Acinetobacter isolates were resistant to colistin. And so if you look at the resistance mechanism, it's really different for different organisms, but it all has to do because of the insertion of the molecule into the lipid bilayer. It all has to do with lipid metabolism, and I'm not going to go into it, but there's this chromosomally mediated resistance, and so, and I'm not sure that I understand it, but it was chromosomally mediated. And then recently, there was a group in China, they were using colistin in their agriculture for, you know, how they use in feed for growth promotion. They were using colistin, and they started to see increasing resistance to colistin. And so they were screening for antimicrobial resistance for E. coli, and they saw this increasing colistin resistance. And they found that there's this one E. coli strain that had the gene for colistin resistance on a plasmid. So remember, it was chromosomally mediated. Now this MCR1 resistance pattern is now colistin resistance on a plasmid. And so you can see they checked, these are mostly in animals, but it was all over China. And then they found it in the United States. And the thing of it is, we may have it and we don't know because we don't routinely check for colistin resistance. So we could have it and just not know about it. But the concern, like with the other modes of resistance, we talked about gene transfer. If you have a population of Pseudomonas or Acinetobacter that's resistant to a lot of other drugs, and they get mixed with an isolate that has the MCR1 gene, the plasmid, you could develop colistin resistance, and then you don't have anything to treat the patients with. So this was found, just the first case in the US was they were screening E. coli, ESBL producing E. coli, and they found one that had a high MIC to colistin, and they looked at it and it had the same plasmid that the Chinese isolates had. And then this study just shows that it's been globally distributed. Anyway, so hopefully this is just a quick review of, and mostly those summary slides, if you think of the different beta-lactam, beta-lactamase combinations, and the kind of the nuances about which one, KPCs is what we're going to see more commonly, and we have ABCAS here on the formulary, we can get it, so if we need it. But the others, for sure, you're going to get an ID console, and we'll try to piece together what's going to be the best treatment. But so questions, yeah.
Yeah, thanks for the talk. One of the questions I have is about antibiotic development and response to drug resistance. And I think historically the thought process was the market didn't want to invest in new antibiotics because you'll use it for a short period of time, you don't get a lot of money out, and so they wanted to invest in kind of chronic medications. It seems like there's more antibiotics coming on market. Have there been, is that your impression as an ID doc? And have there been changes in the market or policies that have helped to support that?
I guess for those on live streaming, the question is about market response to antibiotic resistance. Are there new drugs on the pipeline? Well, yeah, there are. I think there are some companies that still invest, but a lot of the big big pharma companies decided it wasn't worth their, it takes years and billions of dollars to develop a drug. And then they bring it on a market, and then the infectious disease antibiotic stewards say, don't use this drug. We're trying to save it for, so it's kind of a, but like I said, there are some oral carbapenems that are coming out. There's some oral new beta-lactam, beta-lactamase inhibitor drugs coming out. And that's one thing I haven't really looked at what what companies are doing what, but I mean, I think, the long-acting staph drugs, dalbavancin and ritonavantsin are new drugs on the market, which have been really very valuable in our treatments here. So that's a good question, but I think it's going to continue to be a challenge. And unfortunately, there was a big push in the past from infectious disease societies and whatnot, and legislation. I know Sherrod Brown was senator, one of the senators from Ohio, was pushing an act in Congress to support drug companies that would develop, antibiotics, but I can't say how that's doing in the current environment. Other questions? I don't know if Dr. Beecher, Cassie, if you have any comments on dealing with these drug-resistant bugs.
Probably the only one thing I would say is you can't always infer that if it's susceptible to meropenem, that it's susceptible to ertapenem.
Yeah,
There is a resistance gene that will make an isolate resistant to ertapenem, but maintain susceptibility to meropenem, and that's not truly a carbapenemase producing organism. So just probably, and our panels luckily have both meropenem and ertapenem on them, so you can see that, but that does happen sometimes. So
yeah. The other thing, that's a good point. We had a Pseudomonas isolate here, not a couple of years back, that I thought was a carbapenemase produced because it was resistant to carbapenems. We ended up treating the patient with the appropriate drug and they got better. But when we sent it to the state lab to do carbapenemase detection, they said it wasn't a carbapenemase producer. So, so Pseudomonas and Acinetobacter, unlike the Enterobacteriales, they're more difficult to assess because they have so many different mechanisms, and they could be combinations. They could have an efflux pump and a carbapenemase and So anyway, this is always a topic that's bores a lot of people. So, but I wanted, for the residents' sake, to at least be introduced to these newer drugs, because drugs that we don't use here a lot, they could show up on your boards. Anyway, well, thanks very much.
Yeah, I think it's.
I still think there's a sign that says martial arts class.
Yeah. That's already done.
So all these molecular mechanisms, we're trying to make this a little more. I think we want to do. We had a stream. I just had all the different.
Well, you know, well, there's some nice art.
Just really wanted. I think it's probably that annoying. Very few of them. I did have a nice day. Well, I have a page.
Their patients.
I think the most important thing with a lot of these is you have to You still have to look at MIC data.
You're trying to, even if you use it.
Now I have to like see which Quincy Ellen it is.
And then we have